In this particular section, we are going to discuss on a very, very important topic, a mighty important one, that is on Aspergillus lung disease. First, let us see what do you mean by Aspergillus and what are the medically important Aspergillus. To be honest, there are more than 200 species of Aspergillus that are present in the world, but in that only 3 to 4 Aspergillus species are medically important. The first one being Aspergillus flavus, second one being Aspergillus fumigatus, third one being an Aspergillus niger, and the fourth one being Aspergillus terras. In that, very likely your terras may be an exam question because this terras tends to be amphotericin resistant. That's why. So these are the species that carry a real functional significance for humans. And next thing what we have to do is how Aspergillus are getting transmitted. But remember, Aspergillus enters human beings in the form of spores. These spores are called as mold spores or fungal spores or mold spores. And they are typically going to enter your body by inhalational route. You are going to breathe in the spores, literally. That's how they deposit and they cause a disease in susceptible patients, not in all. And where these spores generally are found, actually they are carried away by the natural flow of air. It's like so light so that it can be carried away by the free flow of the air, in the direction of free flow of air. And where these spores generally tend to settle down, where they like to settle, is where the nutrition is seen, typically in water bodies, which means they like water, they like humid areas, especially when they are warm also. Your ventilators play a very ideal role because ventilator gives you the warmth, ventilator gives you the humidity also. So ventilators in ICU are one of the very important reservoirs for this Aspergillus spores. At the same time, they can be deposited over cellulose. You might be asking where cellulose is in wallpapers, in hospitals, very commonly. They can have Aspergillus spores in them. And next thing, they can also be found on the plants, typically, and this is also one reason why indoor plants in hospital is not really advocated, because if you have plants, there is a high chance of transmitting this Aspergillus spores to patients who are really immunocompromised. So don't do that. Don't keep indoor plants inside your hospital rooms, even for your decoration purposes. And now we are going on to the real means, that is the types of Aspergillus lung disease. There are basically 3 types of Aspergillus lung disease. One is called an allergic bronchopulmonary aspergillosis, ABPA, then you have a chronic pulmonary aspergillosis, CPA, then you have an invasive pulmonary aspergillosis, that is IPA. Remember, getting a particular type of Aspergillus lung disease strongly depends on the immunity of the host. Let us see how. Let us put the immunity first in the box and see how you get the disease. Remember, ABPA patients tend to have a hyperreactive immunity, which means it's a type 1 hypersensitivity reaction, which means it's a hyper immune reaction to Aspergillus spores that results in a ABPA. In chronic pulmonary aspergillosis, the immunity may be normal or may be suppressed, but a mild immunosuppression is what you see, not much severe, or it may be completely normal as well. In invasive pulmonary aspergillosis, the immunity tends to be classically suppressed a lot. They will be seriously immunosuppressed, like a patient who's receiving cancer chemotherapy, a patient who's having your post hematopoietic stem cell transplantation, and patients who are receiving long-term high-dose steroids, and patients who have gone for some post-transplantation, solid organ transplant, and after kidney transplant, patient tends to be seriously immunosuppressed. So some immunosuppression will be there, and it tends to be very profound immunosuppression, the one that results in invasive pulmonary aspergillosis. So very important fact is that the immunity is the one that decides what type of disease you're going to get. Whether they invade or not, ABPA, no, definitely they don't invade. IPA on the other end of the spectrum, definitely yes, they 100% do invade, and typically they are angioinvasive, which means they invade the vessels as well, and they can cause disseminated disease also in these patients. And CPA somewhere in between, they can invade or they don't invade in certain forms of CPA. If they invade, they will be definitely non-angioinvasive, which means they don't invade the vessels and they don't cause disseminated disease in these patients. Clear? Then what are the risk factors for getting this disease? In ABPA, there are only two risk factors. There must be some pre-existing bronchopulmonary condition. In general, any bronchopulmonary condition can predispose to your ABPA, but the most important being cystic fibrosis and bronchial asthma. These are the two most important risk factors for developing allergic bronchopulmonary aspergillosis. But in India, you have to always go for bronchial asthma as a very important entity because cystic fibrosis is not common in India. That's why. And as far as chronic pulmonary aspergillosis is considered, you can have a lot of risk factors like a pre-existing cavity. Usually a dead cavity from old tuberculosis forms a very important risk factor. Apart from that, your routine pulmonary conditions like COPD, emphysema, scar tissue in the lungs, all these things can act as a predisposing risk factor. And as far as invasive pulmonary aspergillosis is considered, your immunosuppression plays a vital role. This is the most important risk factor, immunosuppression. Clear? So these are first of all, the basic differences between ABPA, your chronic pulmonary aspergillosis, and invasive pulmonary aspergillosis. But you also have to know the fact that this chronic pulmonary aspergillosis again has three different types of CPA. Number one being a simple aspergilloma. Second one, we tend to call it as a CCPA, otherwise called as chronic cavitary pulmonary aspergillosis, CCPA. The CCPA is also referred to as something called complex aspergilloma. And finally, you have a CNPA, that's called a chronic necrotizing pulmonary aspergillosis, otherwise called as a subacute invasive aspergillosis. Clear? Or minimally invasive aspergillosis, but these terms are generally to be avoided because invasive means usually it goes towards the other type, which you have seen already in the table. So these are the three different types of a chronic pulmonary aspergillosis. And again, final say, the immunity is what is going to play a very, very big role in determining what type of aspergillosis the patient is going to get. Now, without wasting much time, let us move on and see what do you mean by ABPA, allergic bronchopulmonary aspergillosis. It's a type 1 hypersensitivity reaction, which means it's typically Ig mediated. So that is the reason why majority of the patients will have an elevated Ig to very high levels, especially more than 1000, point number one. And let us see the clinical scenario under which you're going to find out this allergic bronchopulmonary aspergillosis. The number one in India is going to be bronchial asthma. If you write Western exams, you can have history of cystic fibrosis also, but in India, always think about bronchial asthma background. So you will definitely have history of bronchial asthma, and there will be a clear-cut history in the last few weeks or last few months. The asthma gets uncontrolled and becomes refractory to treatment, which means they need continuous steroids, continuous oral steroids. Not I'm talking about inhalation steroids, which is a very easy thing to do in bronchial asthma, but they need a continuous oral or parenteral steroids. So they become refractory to treatment. So this will be the background in your exam for sure. This is the clinical scenario you'll be getting. So whenever they become refractory to treatment and the patient becomes dependent on steroids for the control of asthma, you have to think about some few DDs. So you see about a refractory bronchial asthma and think about the differential diagnosis. The topmost differential diagnosis is poor adherence to therapy, which means they are not taking the inhalers properly. Non-compliance. Non-compliance, of course, is the main reason for resistant hypertension and uncontrolled diabetes as well. Second, poor inhaler techniques. Suppose the patient is not having a good inhaler technique, you have to teach them. So these are very trivial things, but still forms a very vital key in treating uncontrolled asthma. Number 3, if the patient is having a continuous allergen exposure, either knowingly or unknowingly. 4, the drugs form a very major role. In general, the two drugs, the beta blockers and the aspirin, they can worsen the asthma to a great extent, and patient may not reveal that they are taking these drugs to you, so you have to review the medical history properly. Number 5 is your allergic bronchopulmonary aspergillosis, ABPA. Number 6, do not forget about Church-Strauss syndrome, which itself can present like a refractory bronchial asthma. Clear? So these are some of the conditions. So once you have ruled out all these conditions, still you have an uncontrolled asthma, you really brand them as uncontrolled asthma and start treating with the higher and higher drugs. But if any of these are there, address those things first. That itself will bring the refractory asthma down to the baseline. Clear? So I told you the patient will have refractory bronchial asthma. And along with that, they might give you a other history, like the patient may have associated sinusitis, even they may have fungal balls within the sinuses. Patient may have associated weight loss and low-grade fever and malaise and fatigue. All these things the patient might have. And the patient may also have associated brownish colored sputum. And this is a very characteristic Indian exam finding. A brown colored sputum with flecks of aspergillus related plugs will come out. This mucus containing aspergillus will come out that form brown flecks of sputum. And that brown colored sputum expectoration is very, very characteristic of ABPA, at least for exams. So this will be the background. And in this background, they might give that the patient has an elevated Ig and the patient is testing positive for aspergillus antigens. The skin test is positive for aspergillus. Boom, you're not going to diagnose anything else here. You're going to only diagnose aspergillus. That is allergic bronchopulmonary aspergillosis in this condition. And in imaging, in chest X-ray, you are going to get some characteristic findings that are again all are exam points. The first one, you can get in long-standing allergic bronchopulmonary aspergillosis, you will get something called a central or a proximal bronchiectasis. What do you mean by a central or proximal bronchiectasis? Very simple. And again, your bronchiectasis is going to be concentrated in the near the major bronchus. Clear? Near the first or second airway generation. Usually bronchiectasis is a typical feature of a third or fourth airway divisions, but here it will be localized near second and third divisions. That's where you're going to get the bronchiectasis here. So it's a central bronchiectasis. Whenever in exam you get this central or proximal bronchiectasis, think only about cystic fibrosis or ABPA. These are the two standard hallmark classic conditions that produce a central or proximal bronchiectasis. Majority of other things will produce only distal bronchiectasis, peripheral bronchiectasis. But here the situation is different. Number 2, you're going to get one other important thing that is called fleeting pulmonary infiltrates. Whenever you hear the term fleeting infiltrates in the lungs, typically that goes towards an eosinophilic lung infiltrate like a tropical pulmonary eosinophilia, or it could be ABPA also. And ABPA, again, the typical thing is the fleeting, the moving character of this infiltrates. They move from one point to another. This is called a fleeting pulmonary infiltrates. And number 3, you might also get this characteristic mucus plugs that you can see. These mucus plugs you can see in the lungs. In certain bronchus, certain airways will be plugged with this mucus, this aspergillus containing mucus. And that resembles one important sign called a finger in glove sign, which I'll show you in some time. So all these are very characteristic imaging findings in ABPA. So you have to be very careful about them. But coming to the criteria, there are a lot of criteria. Roberts and Patterson criteria in 1977 was one of the traditional criteria, but right now we don't use them. Instead, we use modified Isham criteria. Criteria-wise, you can split the diagnosis into 3 possibilities. One is presence of pre-existing disease. This is definitely needed. At the same time, there is something called an obligatory criteria. You have 2 points, and again, both are definitely needed, and you have other criteria. Clear? So what do you mean by your pre-existing condition? The patient should have either a bronchial asthma or a cystic fibrosis, and presence of any one of this is mandatory. You should have this to diagnose allergic bronchopulmonary aspergillosis. Plus, you need obligatory criteria. Obligatory criteria is only two things. One, the patient should have an elevated Ig levels more than 1000. Or second thing, the patient should have an aspergillus skin test must be positive. This is a rapid test. The moment you produce an aspergillus antigen into the skin, that area will get a type 1 hypersensitivity reaction, and that is what we call aspergillus skin prick test positivity. Or alternative to that, you can also prove that aspergillus related Ig is elevated. Aspergillus related Ig is elevated. This is an alternative, but any one. But very commonly in Indian practice, what we do is the aspergillus skin prick test. That's what is supposed to be positive. And in this obligatory criteria, both 2 out of 2 should be present, which means both criteria should be there. And in the other criteria, there are 3 are there, where your absolute eosinophil count should be more than 500 in the peripheral blood. At the same time, you might be getting your aspergillus precipitans positive. Precipitans for aspergillus antigen is positive, which means how we do precipitin test, we take a disc-like structure where the disc will be coated with aspergillus antigen, and we'll be introducing a serum into the disc as the serum from the patient. This is a patient serum. If the patient is suffering from a allergic bronchopulmonary aspergillus, which means they develop antibodies against this aspergillus antigen in a too much. I mean, it's actually too much of antigens, the antibodies they develop. That's why the immune system here is hyper-reactive actually. So there will be a lot of antibodies, and they diffuse out through the gel, and they're going to produce a characteristic precipitation. This is what we call the precipitation near the area of aspergillus antigens. This is what we refer to as a precipitin test for aspergillus antigen, and that is supposed to be positive. Or alternatively, you can also prove that aspergillus specific IgG is elevated at least 2 times the upper limit of normal from the usual titers. Aspergillus specific immunoglobulin G is elevated. And third, chest X-ray or CT findings that are consistent with ABPA. I think I've told you about the chest X-ray and the CT findings, the imaging findings in aspergillosis. So among these 3, 2 out of 3 is needed for diagnosis, which means you need one pre-existing condition, both obligatory conditions, and 2 other conditions, other points which I've told you, which means totally you need at least 5 points. I mean, but you have to match each and everything. It's not about overall 5 points. So you have to have 5 points overall, but it has to match in the subcategories also, and that will give you the diagnosis as per Hisham. It's one of the very highly sensitive and specific criteria for diagnosing ABPA. So there's no doubt about that. And typically treatment includes, you have to give steroids because it's an allergic reaction. You have to suppress the allergic reaction. At the same time, you have to eliminate aspergillus by giving itraconazole. So this is the treatment that we prefer. Clear. So let us move on to chronic pulmonary aspergillosis. Chronic pulmonary aspergillosis, I told you there are 3 different types of chronic pulmonary aspergillosis. One is called a simple aspergilloma. Second one, you have a CCPA, that is chronic cavitary pulmonary aspergillosis. Then you have a CNPA, that is called chronic necrotizing pulmonary aspergillosis. This CCPA is also referred to as a complex aspergilloma, and the CNPA can also be called as subacute invasive aspergillosis. But these terms are not to be avoided. The right term is to use CCPA or CNPA. So in aspergilloma, what could be the nature of aspergillus infection? The nature of aspergillus infection tends to be saprophytic, which means they don't cause any problem. They just wanted to come and live in a place without harming much about other things. Like they come and live in a cavity that is left by a pre-existing tuberculosis. That's a dead cavity, but still aspergillus want to live in that cavity like a cave. So that is saprophytic nature. So that's what aspergillus does here. But in CCPA, it causes slow invasion. It's not a faster invasion, but invasion takes some time. But in CNPA, it's relatively faster invasion compared to that of CCPA. Whereas in invasive pulmonary aspergillosis, it's a rapid invasion because patient is severely immunosuppressed. All this happen within a day or 2. This is the nature of Aspergillus infection in CPA, in different types of CPA. And what could be the risk factors or predisposing factors? Usually a pre-existing cavity, usually it will be a dead cavity, especially from an old tuberculous infection. This is the risk factor. This is a prerequisite for development of simple aspergilloma. CCPA wise, any cavitatory or structural lung disorders, structural lung diseases can be a risk factor for CCPA. Similarly, these patients also may have a cavitatory or a structural lung disease, but apart from that, they do have some evidence of mild immunosuppression. This is the major difference. But these two patients will have a normal immunity most of the time, normal immunity. But CNPA patients also have evidence of some mild immunosuppression like diabetes, alcohol, usage of long-term steroids, old age, elderly patients, malnutrition. All these are some of the standard risk factors, and additional evidence of immunosuppression will be there. The two mild immunosuppression will be there in CNPA. As far as clinical progression is concerned, it is typically non-progressive. Whereas in CCPA and CNPA, it is progressive. But how it progresses? Remember, typically in CCPA, it's a slow progression, whereas in CNPA, it's a relatively fast progression. Slow means it progresses over 3 months period, where here it's going to progress for less than 3 months, characteristically in 1 to 3 months. And this is the most important thing that differentiates a CCPA from a CNPA. Very important point again. Next, what could be the radiological features? Chest X-ray or CT features. Here you are going to get a characteristic fungal ball only. You're going to get only a fungal ball, where the ball will be located something like this. So this is a fungal ball, the black one, and you can see a crescent of error. So let us put a different color maybe. So we can put this is the fungal ball, the green one here. And there will be a thin crest of surrounding air. And this is what we refer to as a famous crescent sign. But currently, this crescent sign is reserved for one more thing which we'll discuss later on. So this crescent sign should not be used for this. But still, books interchangeably use this crescent sign for aspergilloma also. But idea is currently you don't use that. Instead, you call this sign as Monod sign. MONOD-SIGN, Monod sign, where you see a crescent shape air that is present next to an aspergilloma inside a cavity. So this whole thing is a cavity, which means the presence of this cavity is a definite prerequisite thing to develop a aspergilloma. To get an aspergilloma, this presence of cavity is a very important prerequisite. 100% is needed. If you don't have a cavity in your lung, you will not get an aspergilloma. Clear? At the same time, you can prove the positional changes. You can prove the positional changes of an aspergilloma because it is attached to the cavity by a thin stalk. So it moves within the cavity. So you can also prove the positional changes of the aspergilloma inside the cavity by just asking the patient to change the position and take an X-ray or a CT again. So that is also a confirmatory thing about an aspergilloma. Whereas in a CCPA and CNPA, you will get a common X-ray finding that you will get an expanding cavity because it's a progressive disease, which means the cavity is going to expand. You're going to get an expanding cavity. Either it might expand slowly or expand fastly, depending on what is the type CCPA versus CNPA. Plus, they will have a pericavitatory infiltrate. Fungal balls may still be present. So, fungal balls may still be present in these conditions. But this pericavitatory infiltrate is again one of the important hallmark, and expanding cavity is again a very important hallmark. But remember, here this cavity tends to be non-expanding, which means they don't progress at all. At the same time, there is no pericavitary infiltrate in a simple aspergilloma. There's no pericavitary infiltrate. But whereas in CCP and CNP, you're going to have a pericavitary infiltrate for sure because it's invasive. That's why your immune cells come there. What about your invasion? Invasiveness is no. Aspergilloma definitely no. Yes. Invasion is very mild, but in CCP and CNPA, it's only a very, very mild invasion. At the same time, they won't be angioinvasive, but there is no angioinvasion. Okay, what is going to be the treatment? Treatment wise, surgery, one of the best treatments that you can do for simple aspergilloma, because one of the important complications of an aspergilloma is massive hemoptysis. They can go for even massive hemoptysis, collapse and death also, because they erode some vessels over there in the local area and near the cavity. They can produce a massive hemoptysis. So clinically speaking, main treatment is going to be the surgery. But here I'm going to treat medically as much as possible. But remember, here medical treatment will not be effective in a simple aspergilloma because only 25 to 40% effectiveness of antifungal agents are there, which means they don't enter the cavity properly. That's why. But whereas in CCP and CNPA, your medical treatment with typically itraconazole you can use, that antifungal agents you can use, that is going to be the mainstay of treatment. The response rates with medical therapy is 70 to 75%. I told you with medical in simple aspergilloma, it's only 25 to 40%. But here it is 70 to 75% responsiveness, and here it is more than 90% responsiveness. Clear? So antifungal agents are the mainstay in CCP and CNPA, whereas surgery is the mainstay in simple aspergillomas. Can you do surgery in CCP and CNPA? Yes, you can do, especially if your antifungals are not working properly. In that scenario, you can go for a surgical therapy also if you want. So these are the differences between aspergilloma, CCPA versus a CNPA. All are forms of chronic pulmonary aspergillosis. Next, you have another form called invasive pulmonary aspergillosis, that is called IPA. So what is going to happen in invasive pulmonary aspergillosis? First of all, the patient will have definite history of severe and profound immunosuppression. With any example, as I told you, cancer chemotherapy, patient who has received a hematopoietic stem cell transplant, or the patient who has received a solid organ transplant. In the background of history of severe immunosuppression, there will be organ invasion will be there. So the aspergillus can involve the lungs, which is the most common organ that is involved in invasive pulmonary aspergillosis. Second is involvement of the mucous membranes and the sinuses, involvement of skull, and it can even disseminate to different organs. Like dissemination, again, is because of profound immunosuppression. Dissemination can happen to heart, liver, kidneys, eyes. So many places they can go for dissemination. Lungs being the most common, what are the characteristic features of the lungs? They are going to present with fever, cough, typically a dry cough, and pleuritic pain, and they can even have a septic shock. So all these are features of pulmonary involvement. But please do remember, since the patient are in profound immunosuppression, there's a lot of chances that invasive aspergillosis will not come alone. Instead, they might have an additional bacterial superinfection. Almost all the times, they will have additional bacterial sepsis as well. So it's not like they will come only isolated cases. They will be having profound immunosuppression. So there is also a risk of getting other bacterial superinfection and sepsis. Mucous membrane, if they invade, they typically involve the sinus. So Aspergillus sinusitis can happen. Again, the sinusitis will be invasive sinusitis. They involve the surrounding tissue. Skull wise, they can involve the CNS, they can involve the orbit region also, and they can cause CVT, cerebral venous thrombosis, and they can produce orbital involvement resulting in exophthalmos, reduced visual acuity, congestion, chemosis of the eyes, and all these things can happen because of skull involvement. So these are some of the important things that you need to know in a patient who are developing invasive pulmonary aspergillosis. Diagnosis wise, the CT will show characteristically certain signs they will have, but during immunosuppression state, in the early stages, characteristically they will show multiple nodules, which will be non-specific, and you cannot diagnose based on these multiple nodular appearances. Second, there might be a halo sign. So halo sign means you will have a infected nodule that will be having hemorrhage in the surrounding. This hemorrhage in the surrounding is what is going to show us ground glass opacities. Ground glassing in the surroundings. Around these nodules there will be ground glassing. So that is very characteristic of invasive aspergillosis, and it's called a halo sign. At the same time, during late stages, especially during recovery stage, immediately if you give a GCSF or something else to improve the counts, because these patients I told you will have neutropenia and profound immunosuppression. Right? Many of them will have a neutropenia and a profound immunosuppression. So if you give some drugs and you improve the counts, now they're going to generate an immune response. They're going to mount an immune response. So initially it was like this. Now they will generate an immune response. So which means there will be a mass of Aspergillus lung disease. In that, they might cause lysis of the necrotic area, because when they start mounting an immune response, when the cell count increases, these cells that are immune cells that are going to mount an immune response in that area, and they're going to cause removal of this necrotic particles. Once they start removing these necrotic particles, this area will be filled with this air because it's a lung, and that's what we refer to as air crescent sign. Air crescent sign. And they're going to cause something called a air crescent sign. Remember, the similar air crescent that you see in simple aspergilloma, you should not call as air crescents. Instead, you should call as monod sign only, which we have discussed all. That's why I told you air crescent some books interchangeably use that also, but do not use that air crescent word. You instead use a monod word, monod sign. So this is what we call air crescent sign. At the same time, it's very difficult to find out invasive aspergillosis in a patient who's having such a profound immunosuppression. Instead, you can only predict the presence of invasive aspergillosis, especially if the fever doesn't settle even after 48 days of antibiotics in a patient who's suffering from a febrile neutropenia. Then you can think about as invasive aspergillosis as one probable cause, because fungal infections in neutropenia again is very common. So that's why. But you have some assays that you can do to find out invasive fungal infection. Like you can do serum galactomannan. You can do a serum galactomannan. But the problem with this galactomannan is this galactomannan tends to be falsely positive in patients who have used penicillin, because penicillin group of drugs, beta-lactam group of drugs are coming from penicillium. And again, it's a fungus, and again, it will have a galactomannan contamination in them. So galactomannan can be falsely positive in patients who have used penicillin already. And this is really the fact. Many patients would have used this beta-lactams already in a patient who's having especially profound immunosuppression, because we know these patients are having profound immunosuppression, and many of the patients would have already been on antibiotics even before they develop this aspergilloma. Even before they develop this invasive aspergillosis. That is the reason why galactomannan assays are generally false positive in these patients. Number 2, you can use beta-D glucan assay. Beta-D glucan assay, otherwise referred to as something called a 1,3 beta-D glucan assay. But the problem with this 1,3 beta-D glucan assay is it can be again falsely positive not only in aspergillosis, in 2 other conditions. a candidemia or a candidiasis, a candidial sepsis, or you can get in a PCP pneumonia also. Pneumocystis carinii pneumonia, apart from Aspergillus. Remember, the important false positivity reason for galactomannan testing is penicillin use. An important false positivity reason for beta-D-glucan is candidemia or PCP also. Again, these are very important culprits when you are dealing with the immunosuppressed patient, because in immunosuppressed patient you can get a candidemia also, in immunosuppressed patient you can get a pneumocystis carinii pneumonia also. Both can show, all three can show positivity for beta-D-glucan. So that is why these investigations has its own positives as well as negatives, so you have to use very judicially and in a very justified manner. Suppose if CNS infection is suspected, you can do an MRI. Otherwise, MRI is generally not needed. How will you confirm? The CT can suggest, beta-D-glucan can suggest, but confirmation is only based on a BAL. You have to do a bronchoalveolar lavage through bronchoscopy, and you have to prove the fungal elements. And you have to prove the characteristic Aspergillus fungal elements you have to prove. And to prove the fungal elements, I'm going to stain with a stain called Gomori methenamine silver. That's called GMS, very, very famous stain for fungus. Even for PCP, they use the GMS stain. So we are going to use this GMS stain, Gomori methenamine silver stain, to show it's a fungal element. And how Aspergillus will be seen is narrow based. It will not be broad like this. It will be narrow based, typically hyphae, and they'll be septate. These are narrow based septate hyphae, and they have this kind of dichotomous branching. Dichotomous branching. What do you mean by dichotomous branching? So what I'm drawing is actually a dichotomous branching. I don't know, people who have studied botany well might really know what do you mean by a dichotomous branching. Clear? There are many types of growth. So first, our tree can grow something like this also. Straight, like the main stem will be growing, and side you will get branches. This is one type of growth. And a tree can grow laterally like this also. This is also another type of growth. A plant can grow like this also. This is another type of growth. This also has a growth. And third is the dichotomous growth, where the tree grows through all the branches like this. Typically, this is how the child draws a tree, isn't it? So which means every single terminal branch is going to grow by itself. So which means the entire growth of the tree is based on the growth of all these terminal branches. Then again, these terminal branches will again grow again. So this is what we refer to as something called a dichotomous growth. And typically, this Aspergillus related hyphae will be septate, and they will be having this kind of dichotomous growth. They'll be septate and they'll be having dichotomous growth, and this is what is characteristic of Aspergillus. At the same time, the angle between this septum, angle between this hyphae will be acute angles. It will be very less. It will be acute angles. Why I'm telling this much clarity about this is because you have another thing that confuses often with Aspergillus, which is also seen in immunosuppressed patients, is mucor or zygor. But mucor will have a broad base. It will not have septations, very limited or no septations. It's aseptate typically. And they will not have this acute angle, and they don't have this dichotomous branching. They branch irregularly and haphazardly, irregular branching, and they will not have the septae, and they'll be broad based, not narrow like this, and they will not have that acute angle. Instead, they'll have a 90-degree mark. So most of the branches will be at 90 degree in mucor. So that is why I'm telling this characteristic features of Aspergillus, which I'll show you the image in some time. So how you're going to treat this invasive pulmonary aspergillosis? If you know it's an invasive pulmonary aspergillosis, treatment of choice is IV voriconazole. That's it, nothing else. IV voriconazole, that's all. That you have a lot of alternatives, like you can use an IV amphotericin B. In general, we use this amphotericin B if you don't know the disease properly and you don't have a typical isolation of fungal elements. You have not seen that fungal element. In that condition, you can prefer an IV amphotericin B as an empirical treatment, but this is only an alternative, but the best is always voriconazole. Or you can use IV isavuconazole also. Isavuconazole. Remember, there is no role for oral drugs here. like itraconazole and all. Itraconazole should be reserved for patients who are having milder forms of Aspergillus infection like CPA or ABPA. But here in invasive pulmonary aspergillosis, I'm going to use only IV drugs. Best is voriconazole, alternative is amphotericin B and isavuconazole. So let us see some at the end. So this two we have seen already in the previous video itself. This is something called a steeple sign. Just a recap, this is steeple sign because you can see this is a subglottic, swelling and stenosis, and you can see small tapering of the airways. That is what we call steeple sign. And this is typically a laryngeal diphtheria. I can see the pseudomembrane of the diphtheria, which we have discussed. These two images we have seen already. I'm not going to discuss once again. This is simply a croup. In croup, you will get steeple sign. This is a laryngeal diphtheria. So just a recap, because I'm discussing the same image once again. So this is a recap only. But what you're seeing here is something special. From here on, you're going to see Aspergillus related things. Can you see this characteristic mucus plugging of the airways? So this is what we called as a characteristic finger in glove appearance or finger in glove sign. Here also you can see this mucoid impactions. You can see these are the mucus that are seen as plugs. So you can see in some other areas also, probably here also you are seeing one mucus plug here. So this is also mucus plug. So this characteristic mucus plugging is very, very important. At the same time, you might have central bronchiectasis, which is not shown in the image. Plus at the same time, this mucus plugs I have explained here also. You can see these are the characteristic mucus plugs that you are seeing. So all these things, these are images that are special for diagnosis of ABPA, allergic bronchopulmonary aspergillosis. And this is a simple aspergilloma. Simple aspergilloma, where you are seeing a thin crescent of air. I think you can see that. But remember, it is very loosely attached. This aspergilloma is loosely attached to the cavity. It just lives in the cavity, leaving a small crescent of air called a crescent sign. I mean, you should not call it as a crescent sign. Instead, if you get in a simple aspergilloma, even though it looking like an air crescent, this has a special name called a Monod sign. This is to avoid the confusion with the name crescent sign that you usually use for invasive aspergillosis. And you can see here, this is what we refer to as a characteristic halo sign that is seen in invasive pulmonary aspergillosis. So where you are seeing a nodule surrounded by a hemorrhage causing ground glassing. So surrounding, you have this ground glassing surrounding a nodule, and this is what we called as a halo sign, very typical of an invasive pulmonary aspergillosis. If you see this in a patient who is not responding to antibiotics and having a febrile neutropenia, immediately start with antifungal agents. This is a very specific sign in the appropriate clinical setting, not in all the settings. This is an invasive pulmonary aspergillosis. And you can see once again, this is what the typical air crescent sign is. This is specific again for invasive pulmonary aspergillosis, and you're going to see during the recovery phase, not during the immunosuppressed phase. During the recovery phase, once you have started with some drugs and the neutrophil counts begin to recover in immunosuppressed patient, that time there will be resorption of this necrotic material, and the places where the resorption has happened will be filled with air, forming a crescent-like appearance called a crescent sign. And this happens during, remember, recovery phase of invasive pulmonary aspergillosis. Again, very, very specific. And if you see the two things I have compared here, because these are very important for differentiating as far as exams are concerned. So this is an typical aspergillus, typical to typical aspergillus, where you can see characteristic dichotomous branching. You can see this is what we call, if we go closely and see, this is what we call this characteristic dichotomous branching, which might branch again here. So this is a typical dichotomous branching which you have discussed. And if you see the angles between this hyphae, it is acute angle, which is less than 90 degree. It is usually around 45 degree mark, that much only. So it's an acute angle. And you can see numerous septations here. These are all septate hyphae. Clear? Lot of septations are there. These are septate hyphae. You can see one lot of septations here. Clear? So this is very, very typical. If you see this picture itself, we have to be very clear it's an aspergillus. And obviously with the current need pattern and the current pattern that you're getting in exam, always going to reflect a clinical picture. So it's going to be even more easier to find out these images. And this is a typical mucor. Usually this kind of mucor-like images you will get in a patient who's a diabetic characteristically coming with a rhinosinusitis plus or minus a blackish discharge plus or minus patient will be septic and very profoundly toxic and very serious. They can be hypotensive as well. So this will be the history, and this mucormycosis typically. Mucormycosis I have seen even in the stomach also. Gastric mucor also I have seen in certain CKD patients. 2 cases we have reported in the last 2 weeks. But typically this is what the exam pattern. This is what you will get in a mucor in case of the exams. But what you are going to see in the histology, that's what is going to tell you whether it's mucor or aspergillus. In mucor, what you are characteristically seeing is the broad hyphae. You can see these hyphae are generally very, very broad. Number one. Compare with that of the hyphae of aspergillus, which tends to be very, very narrow. But compare here, this very broad hyphae and typically aseptate. You can't see even a single septation here. Aseptate. And they have irregular branching. They don't have that regular branching like see here how regularly the branches are, and they go like a dichotomous, like a bush you see, the branches. That's how it is. Aspergillus. But here you don't have this branches in a very regular. See the branching here. You cannot call them as dichotomous. It's really like irregular branching here and there. It's not dichotomous. Broad based. At the same time, major times you can see they have variable angles, but very commonly they will have this 90-degree angle between the hyphae. You can see major times they will have an angle of 90-degree. You can see here and here it is almost 90-degree here. So they won't have these acute angles like aspergillus. So it's very typical of a mucor. So it's very important. These 2 images you have to keep in mind. Narrow-based, septate, acute angles, dichotomous branching is equal to aspergillus. Broad-based, hyphae, aseptate or very less septations and irregular branching, non-acute angles, especially at 90-degree branching, go for mucor as the differential diagnosis. Clear? At the same time, I didn't tell you this point, CCPA and CCNA, many times it's very difficult to diagnose. Diagnosis is going to be extremely difficult in these conditions because the most important differential diagnosis for this is TB, because you might have a cavity and you might have a surrounding infiltrate. Cavity with a surrounding infiltrate, you might get in a TB also. So many of the patients will be treated as TB. They will be given empirical anti-tubercular drugs and they don't respond to that. And after that, you take a ball and you see the fungal elements, and then only you diagnose it as a CCPA or CCNA. That's why CCPA or CCNA is going to be a real challenge for diagnosis. It's not that easy to diagnose a CCPA or CCNA because many times they might have a cavitating lesion with the pericavitatory infiltrate. Again, this cavity with the pericavitary infiltrate in India, we take it as TB unless proved otherwise. So that's why many patients will receive empirical anti-TB drugs. And later on, when they don't respond, still the cavity persists or even it's expanding, then you might go for resistance check. How do you check the resistance? You have to obviously do a ball, take a wash and send for culture. But what you see is not the resistant TB. You will see something extremely that comes as a surprise, that is a aspergillus. So then you treat for aspergillus, they respond. So that's also one way of, like framing an exam question in a case-based scenario, which is very common scenario that happens in India. Okay. With this, I think we have completed the ever important topic on pulmonary aspergillosis. So I think I have classified it in a neat way so that you can understand them better. So these are the maximum thing that you have to know about aspergillus related lung disease, and let us move on to the next section and we terminate this thing here.